Good afternoon, our dear students. Today we continue our lectures in Propaedeutics of Internal Medicine and submodule Signs and Symptoms of Respiratory System Disorders. And topic of our today's lecture it is syndrome of diffuse and focal consolidation of lungs. For today it is very actual and very important topic because all of you know that we have pandemic of COVID-19, and one of the main problems, one of the main clinical syndrome in this disorder it is pneumonia. And pneumonia it is one of the most important disease in this syndrome. One of the most important, but not it can be not just pneumonia. Let's discuss more. And a short preamble about importance of respiratory system. Yes, for understanding the importance of this system, I want to say that since our childhood we all are aware that food, water and oxygen are basic necessities of life and we can't survive without them. An average person can live without food about 3-4 weeks. We can't survive without water for more than 3-5 days. And oxygen is crucial to sustain life, and even 3 minutes is the maximum time where a person can stay alive without breathing. That's why all disorders of respiratory system, all problems with respiratory system are very important because they affect very much the quality of life of the patient. They had a huge risks of death, huge risk of morbidity and mortality for such patients. That's why all diseases of respiratory system are the very important problems in modern internal medicine in all world. What is lung consolidation syndrome? Let's give definition to this syndrome. A lung or pulmonary consolidation is a region of normally compressible organ tissue that has filled with liquid, a condition marked by induration, swelling or hardening of normally soft tissue, of a normally aerated lung. And here you see the picture. It is photograph shows many alveolar spaces filled with inflammatory infiltrate. It is the most often manifestation of lung consolidation syndrome when it is inflamed, when it is present edema and infiltration of lung tissue. Consolidation occurs through the accumulation of liquid in alveoli and adjoining ducts and is defined as alveolar space that contains liquid instead of gas, like in this picture that I show you here and showed in previous slide. The liquid can be pulmonary edema, yes, and you remember where we discuss this case, the most often problem that can lead to pulmonary edema, it is right heart failure. Hope you remember lecture about heart failure. Moreover, it can be inflammatory exudate in different inflammatory disorders, infection, non-infection inflammation, autoimmune inflammation, any case of this. Moreover, it can be pus, it can be inhaled water or blood from bronchial tree or hemorrhage from pulmonary artery. What disease can be with lung consolidation syndrome? First of them, I told you, it is pneumonia. It is a huge number of different causes of pneumonia can lead to it and can lead to lung consolidation syndrome. It is one of the most important syndromes in respiratory system disorders. Infections like lung infections, it can be actinomycosis, it can be ascariasis, it can be aspergillosis, invasive infection or allergic. It can be blastomycosis, it can be cryptococcosis, it can be hydatid cyst and syphilis. It is moreover typical infections that lead to pneumonia. It is pneumococcus, streptococcus, staphylococcus, and other bacterial. It is viruses, it is flu, it is COVID, it is other types of viruses. Moreover, it can be tuberculosis. We will talk more about it and more information in your physiatry courses. And nearly all types of infections, as parasitic, fungal infection, viral infection, bacterial infection, can lead to some inflammation in lung and, like a clinical manifestation, lung consolidation syndrome. We told it, and one more time, it can be pulmonary edema or fluid in the lungs. Yes, most usual case it is right heart failure with decompensation. Lung consolidation syndrome can be caused by tumors of the lung. And another case, it can be caused by atelectasis or collapsed lung. Symptoms of lung consolidation syndrome. First symptom, and the most often, it is dyspnea, which is dependent on the extent of consolidation. It can be abnormal or bronchial breathing sound when you auscultate this patient. It can be coughing. It can be pale or acrocyanosis. During percussion, it can be dull note, yes, when it present consolidation, yes, you understand that it become more dense, and during percussion, it can be more dull sound. During palpation, you can feel tactile fremitus. It can be vocal resonance, it is palpatory method, one more palpatory method. It can be possible medium, late or pan-inspiratory crackles during auscultation. And one more interesting picture for you in right upper angle. It is high resolution CT scan at level of lower lung zones show extensive crazy paving pattern involving both lower lobes, lingula and middle lobe, and in association with areas of air space consolidation. You see consolidation on CT scan and on X-ray, like more dense tissue in more white color, less dense in more black color. And here you see a huge region of white consolidation, and all other tissue of lung. It has a very dense structure, yes, and near the bronchs, near the basis of lungs, it is a lot of very consolidated tissue. More symptoms. It can be egophony. What is this? It is said when occur when during auscultation patient says the letter E and examiner has the letter A. Moreover, it can be pleural friction rub, the sound made by treading of fresh snow. Yes, when it is connected with pleura and pleura has inflammation, in some cases you will learn pleuritis. It can be sound that we named pleural friction rub. To describe how it looks like, yes, here the explanation, it is trading of fresh snow. Or another side to feel the sound near like this, you can do like this, and you can hear something like this sound. Another symptoms, it can be unilateral reduction in chest expansion and lower expected pressure of oxygen, partial pressure, than calculated in the alveolar gas equation. It is specific symptom for pneumonia and lung consolidation in general. Examination of patient with lung consolidation syndrome. On examination, decreased chest expansion may be noted on the affected site and dullness to percussion. On auscultation, findings include bronchial breath sounds, inspiratory crackles or crepitations, and increased vocal resonance and pleural rub. Yes, and we have new picture. Yes, it is X-ray of chest of patient with left lower lobe consolidation. Here it is a patient with pneumonia, and you see at the left lower lobe of lung near the heart. The tissue of lung more white than other color of tissue. It is sign of consolidation. Let's discuss more about pathological process that goes during consolidation in lungs. Pneumonia with pus filling the alveoli is the most common cause of acute consolidation. Other acute causes include blood from hemorrhage or contusions and transsudative fluid from pulmonary edema seen in heart failure. Here you see chest X-ray with more diffuse consolidation. It is connected with left lower lobe too, but near the heart you see that the region with white coloration and with consolidation it is much more intensive than, for example, in previous picture. Chronic consolidation will be likely due to malignant process. Unfortunately, it is the most often cause of chronic consolidation. Bronchoalveolar carcinoma, lymphoma, and lung neoplasms with post-obstructive pneumonia result in malignant cells, causing the consolidation seen on radiography. Yes, here right upper lobe consolidation, you can see it here. If you remember topographic anatomy, you remember where it is projection of right upper lobe, and in this region here you see the place of white coloration, and we understand at this chest X-ray that it is place of lung consolidation. Chronic consolidation will be likely due to malignant process. Bronchoalveolar carcinoma, lymphoma, and lung neoplasm with post-obstructive pneumonia result in malignant cells causing consolidation seen in the radiograph too. And here it is right-sided consolidation multilobar. You see that nearly all projection of right lung and part of left lung, it is in white column. It is consolidation, diffuse consolidation of all lobes of right lung and partially left lung. Chronic post-infection diseases such as organizing pneumonia or eosinophilic pneumonia as also causes with alveolar proteinosis and rare cause resulting in alveoli filled with protein. Here you see right upper lobe consolidation too. Here you see, like in two pictures before, that it is right upper lobe, but you see it's not like apex of lung. Its projections usually look like in some middle part of or a little bit upper than middle of right lung. And you see here in this play some white colorations that mean consolidation of right upper lobe. How to confirm lung consolidation syndrome? Yes, first of all, it is radiographic features. You see that for previous slides from all those pictures that on first place it is radiography or chest X-ray that help us to determine place, localization, and maybe sometimes cause of lung consolidation. What radiographic features we can find? Consolidated areas are radio-opaque on chest radiograph and chest CT compared to normally air-filled lung tissue. You remember from those pictures that consolidated more white color and normal-like tissue on CT and chest radiography it more in black color with structure of small vessels and small bronchs. The distribution pattern of consolidation can aid in narrowing the potential differential diagnosis. Lobar consolidation. It is consolidation of one isolated lobe, where increased density or opacity is seen in individual lung lobes. Sharp delineation can be seen when consolidation reaches a fissure, since it does not cross. Ear bronchograms can also be seen due to bronchi becoming visible against the dense diseased tissue. Volume loss is usually not seen in this lobe. If it is diffuse consolidation, when it connected not just with one lobe, most commonly due to heart failure, I told you about it, resulting in other signs such as increased cardiac size, curly B lines. I told you a little bit on in lecture about heart failure. I will show you this lecture one more time, curly B lines. It can be redistribution on pulmonary blood flow and pleural fluid. Other findings can include multiple ill-defined opacities progressing to diffuse spread seen in bronchopneumonia and whiteout of lung due to progressive consolidation from bronchoalveolar carcinoma. What is curly B lines? One more time. There are short parallel lines at the lung periphery. These lines represent interlobular septa, which are usually less than 1 cm in length and parallel to one another at right angles to the pleura. They are located peripherally in contact with pleura, but are generally absent along fissural surfaces. Here you see chest X-ray radiograms. In the left picture, it is normal lung tissue. Yes, we see near the middle of chest some structure of bronchs and vessels, and on periphery we can't see nothing. And in right picture, at periphery of line, you see by a red color arrow. Like it's parallel small white lines, yes, near the ribs border at periphery of lungs. These small lines we named curly B lines. It is a sign of pulmonary congestion and maybe possible pulmonary edema that, connecting to our lecture, can lead to diffuse lung consolidation. And another variant, it can be multifocal consolidation. Multiple areas of opacity seen through the lung most often is due to bronchopneumonia, starting from bronchi and spreading outwards. Usually ill-defined with peripheral distribution. Neoplasm such as primary malignancy or metastasis can also cause this picture. Here you see multifocal consolidation on a radiograph of patient with bronchopneumonia, and you see that it present consolidation in left lung, but you see by arrows that it not local or diffuse, but the same consolidation. It is several places. It is several foci with places like rounds of consolidation that looks like white rounds, white color places in chest radiography. X-ray patterns of consolidation. Yes, one more time, let's generalize. Consolidation may be complete or incomplete. Yes, when it is complete, for example, in atelectasis, yes, when it is collapsed lung and the density of tissue is near with other not soft tissues. The distribution of the consolidation can vary widely. A consolidation could be described as patchy or homogeneous or generalized. And consolidation may be described as focal or by the lobe or segment of lobe affected. And here you see the example, the picture of X-ray where is abnormal opacity of the right. You would see by small white arrow. There is also loss of clarity of the right hard border known as silhouette sign. Opacity of the affected area on a chest X-ray, it can be lobal or lobe. Loss of clarity of the hard border, diaphragm, or the vertebral bodies, yes, or thoracic vertebra. And here you see a very bright picture. It is very dense consolidation that's shown in this chest X-ray in area of lung inflammation, indicating the presence of pneumonia. And from anatomy, you remember that it is right upper lobe. Another X-ray features. Patchy consolidation may be seen with bronchopneumonia, while confluent consolidation seen in lobar pneumonia. Cavitation, bulging intralobular fissures, and pleural effusion may also be evident in some cases. The picture is the same with previous one. Okay, and let's discuss, let's repeat one more time topographic anatomy of lungs and the result if it is lobar damage of one lobe, how it will be look like on chest X-ray. Like example, right upper lobe. In the first picture you see the projection that it affected in a front space, it affected all upper part, but you remember from previous picture it can be not all upper part. For example, some part of upper that look like middle of lobe, it sign of affecting of right upper lobe too. Two different with other lobe damaging, because yes, it is upper but seen in the middle. You should do another lateral view, and on lateral view you see schematically it's seen where the projection of right upper lobe, and you see the X-ray of real patient. In upper picture or in upper X-ray you see that it is some consolidation, some white coloration in upper part of right lung, but it's not go till the apex of lung, and we are not sure about upper lobe. And in this case we do lateral view, and here you see how this picture it's look like the scheme. By the scheme you see it is diagonal, and upper the diagonal it is some upper part. And on X-ray you see how good it's seen here, this diagonal between lobes, yes, and here in lateral view very good visible affecting of right upper lobe. Okay, it can be affecting of right middle lobe. You remember that in right lung it is 3 lobes. What about middle lobe? Yeah, usually it's seen like in this real first chest X-ray in the middle of right lung too. Usually it is little bit lower than upper lobe, but in the front view you can't be completely sure. For example, with this picture here, first picture, and here first picture, yes, they are upper, here a little bit low, they are different, but you can't be completely sure. And one more time, to confirm your diagnosis, you should do lateral view. And in lateral view, according to scheme, on scheme you see how it looks, the projection of right middle lobe, and here you see that it is under the diagonal and in lower part of triangle. It means that it is affecting of middle right lobe. In a lower right lobe, yes, it usually often always affected the lower part as in front view, as in lateral view. Under the diagonal you see the intensive white coloration. It is intensive consolidation. Yes, and be attentive schematically. It can affect most of the lower part of right lung, and in lateral view it is all space under the diagonal between these lobes. It all lower lobe. And in this real chest x-ray you see this bright picture too, that on first picture in front view it is affecting of nearly all lower part of lung, and you can even different when it's starting diaphragm, no border of diaphragm. And in lateral view it confirmed affection of right lower lobe. You see that under the diagonal, intralobal diagonal, it all affected area. Left upper lobe. Here a little bit even more difficult to differentiate. Left lung consists of two lobes, upper and lower. You remember it, but their projection, their anatomy a little bit difficult. Why? Because, for example, here you see projection schematically of left upper lobe. Yes, and if it affected, it can be coloration, it can be a picture of consolidation nearly in all part of a left lung. Yes, just small piece of left lung usually not affected. Yes, and you see in first X-ray that here nearly all space of left upper of left lung have some white coloration and consolidation. And how to determine, is it upper lobe, is it lower lobe, or maybe it is diffused? Yes, like in previous example, we must do lateral view in the at the affected side. And here you see that by the scheme that here the diagonal, intralobal diagonal 2, as at right, as at left, yes, they are connect to each other by diagonal, and upper lobe it is above this diagonal. And the last picture in X-ray of patient from previous X-ray, when we do lateral view, yes, here become a very understandable that it is specifically upper left lobe, yes, and not affection of lower lobe. And for comparison, consolidation of left lower lobe. Yes, in a front view it is difficult to understand something, because here nearly the all space of left lung in a front view can be affected too, like in previous case, like here. Yes, nearly all space of left lung. Nearly here it is some consolidation. Here is not very intensive, but we can see it, but it not specifically affect some part. It can be usually affect nearly all place of left lung. And for confirmation we do lateral view, and in the lateral view in this case we see that it is consolidation and one coloration of X-ray picture under the diagonal, and in lateral view we specifically see that it is affected the left lower lobe and consolidation of left lower lobe. Moreover, I told you that the main diagnostic test, it is X-ray, CT, or simple chest X-ray, but additionally to it, it can be used another methods, and one of the methods it is lung ultrasound. The consolidated lung is hepatitized, locally similar to liver. It's what I showed you, yes, that consolidated tissue, yes, become more dense. On X-ray, it become more white picture, and when we told that it can be absolute and non-absolute. Absolute consolidation, the maximal dense of lung tissue, it is comparable to dense of liver tissue. Yes, it is like a gold standard for consolidation for dense of our soft tissues. And in maximal case, lung consolidation can reach level of dense of liver consolidation. That's why the consolidated, completely consolidated, we can name like hepatitized. Extensive consolidation of a whole lobe allows the opposite pleural line to be seen from 8 to 11 centimeters deep, with mediastinum deeper and with the aorta or IV spaces still visible. Fully consolidated lobe may be seen floating in pleural effusion. Yes, and it is last part, but it will be not a very short, that I named this part of lecture. It is pulmonary consolidation with fever is not always pneumonia. Yes, first of all, and every doctor, every specialist, when we see patient with consolidation, with clinical symptoms, consolidation on X-ray, and fever, first of all, we always do about pneumonia, but you have to be very attentive because not always pneumonia. Now I detailized. Microscopic, like an example, polyangiitis, it is autoimmune disorders defined as systemic necrotizing vasculitis with few or no immune deposits affecting small vessels, like capillaries, arterioles, and veins. Although MPA, this microscopic polyangiitis, can involve any organ, renal and pulmonary involvement predominate. Pulmonary involvement can present from fleeting focal infiltrates to massive lung hemorrhage and hemoptysis secondary to alveolar capillarities. Yes, you understand, it goes with fever, it goes with pulmonary consolidation. And if you focus just on pneumonia, you can miss such a danger and such an important disorder like microscopic polyangiitis. I want to give you some interesting case. This is a case of 39-year-old male who was admitted to hospital due to fever of unknown origin. He was an ex-smoker, stopped 3 years ago, and his medical history is unremarkable. 10 days back, he was examined by his doctor due to fever, fatigue, and dry cough. He was diagnosed as having pneumonia. The patient had normal breath sounds with normal blood gases and his temperature was 38 Celsius. Laboratory studies revealed white cell count at a level of 19.9. Yes, a little bit elevated. Neutrophil 79, lymphocytes 11.5, monocyte 8.5, eosinophiles 0.6. Yes, it is formula of this patient. Hemoglobin, it is at rate 13.7 grams per deciliter, and erythrocyte sedimentation rate, it is 72 millimeters per hour. Yes, you remember normal, it is very significant elevation of ESR or erythrocyte sedimentation rate. Renal, liver function and urinalysis were normal. An arterial blood gas measurements while the patient was breathing room air demonstrated Pressure of oxygen is at level 88 millimeters hydrargium, and partial pressure of CO2 is 41 millimeters hydrargium, and level of pH in arterial blood gas measurement is 7.39. Chest radiograph at this patient revealed a consolidation in right upper lobe. You see in this picture that in the middle and a little bit upper from the middle, it is some place of consolidation. Here it is no lateral view of this patient, but by the front view we nearly understand and know that it is a sign of consolidation of right upper lobe. Okay, what first of all we should do in this case? We have patient with no any significant history, yes, some smoker, no serious illnesses previously, and patient with fever and symptoms, and on X-ray consolidation of lung tissue with affection of right upper lobe. Yes, of course, first of all we think about pneumonia, and firstly doctors in this case did the same. Yes, they diagnosed pneumonia. This patient was admitted in hospital and began treatment with moxifloxacin 400 milligrams once daily. Yes, it is initial antibacterial therapy. Sputum and blood cultures were obtained and serology tests were conducted to rule out bacterial or viral infection. A new radiograph showed an increase of consolidation, not even on base of treatment. Yes, it was worsening and increase of zone of consolidation. Due to non-resolving or the shadowing on X-ray, the treatment was switched to T-carcellin, potassium plus teicoplanin. Yes, it is combination of other antibiotics that more specific and more significant for some more rare infection. After it was repeated chest radiogram few days later, and it showed worsening of consolidation. You see this chest X-ray that consolidation of right upper lobe become much more intensive and bigger in size, even after such several antibiotics, including a very serious antibiotics. Chest spiral computer tomography showed a few enlarged lymph nodes in the paratracheal and carinal regions, up to 1.5 centimeters in short axis. Apart from the consolidation in the right upper lobe, CT revealed multiple nodular lesions, some with central air bronchogram scattered in all lobes, more prevalent in upper and middle lung fields. Thickened bronchovascular bundles were seen, some connected to nodules. Here you see picture of CT scan of our patient. Picture A or upper picture on CT obtained at presentation shows air space consolidation in the right upper lobe and a nodule with air bronchogram in the left upper lobe. You see this picture, and at picture B, it is HRCT reveals development of extensive areas and ground glass attenuation as well as thickening bronchovascular bundles by arrows. You see that it is process become more diffused, and on CT, like in first picture, like in later CT, we see the affecting of some lymph nodes. Here, at picture A, at CT, it is multiple nodules in both lungs connected to thickened bronchovascular bundles. Yes, bundles are thickened. We see some white consolidated structures that connected by lines with the thickened bronchovascular bundles. And on HRCT, It is resolution of some nodular opacity at the right lung and patchy ground glass opacities is both lung fields. Newly developed ground glass areas surrounding nodules in the left lung. A CT sign strongly indicative hemorrhagic infiltration. It showed here by arrows. Here another CT pictures. Yes, as usual, initial spiral CT. At the level of basal segments of the lower lobes shows a rather smooth nodule in the right lower lobe. Yes, if affection main infiltration on X-ray was in right upper lobe, on CT we find much more another changes as in and in lower lobes too, like here these smooth nodules. At picture B, it is HRCT by follow-up. It shows hollow or ground glass surrounding the nodule and neighboring peripheral bronchovascular banding thickening. You see by the arrow this thickening. Our conclusion of this clinical case, taking into account the febrile patient and non-resolving pneumonia, the differential diagnosis was bordernet widespread infections, tuberculosis, very thickened bronchovascular bundles connected with nodules and lymphadenopathy, indicated Wegener granulomatosis and lymphoma. Yes, you see that it on usual chest X-ray and by clinical picture and initial stage it looks like typical infection pneumonia, but just the one sign from the first analysis was suspected. It was blood test and level of ESR 72. It is huge ESR, and in this moment we should suspect small suspicion, but it present that it can be something more than usual infection, because for usual, for example, pneumococcus pneumonia 72, it is too much. When we see such a high ESR, we usually do about autoimmune, or we usually do about cancer, about some malignancy. And here in the course of disease after CT, it was diagnosed Wegener granulomatosis, or it can be lymphoma. And here it was diagnosed this condition. That's why it is example. By this example, I want to show you that yes, 70% of your patients, of your future patients with consolidation, will have pneumonia. All of them will have typical clinical picture and will get typical treatment for it, but not always. And be very, very attentive. Don't lose a good moment to diagnose and start treatment another, and in most cases even more serious and more dangerous disorder than pneumonia, like here in autoimmune cases. And especially be always attentive with some cancer signs. It can go with fever and with typical lung consolidation too. And during treatment pneumonia, even doctors in practice very often waste time with non-diagnosing of cancer and wasting time for normal starting of treatment of cancer during treatment of pneumonia. That's why this problem is very important. More information you will get with your teachers in practical classes. Please read at home. As usual, if you have questions, you can write it here in comments. You can write them in our Facebook page of our department. I ask you, as usual, to write your name and group for those lecturers who heard my lectures. And for today, goodbye. Maybe for this semester it was the last lecture, and we continue our cycles of lecture in Propaedeutics next second semester in February. That's why have a good holidays, have a good winter, and see you at our lectures next semester. And now goodbye.